like to welcome those attending virtually to meeting two of my favorite people and two of the most knowledgeable people I know, not only about pulmonary fibrosis, but also about fitness and living and lifestyle. And I'm going to start with my good friend Elizabeth Estes with Three Lakes Partners. And Elizabeth is one of those people that's, I call her a force of nature because that's what she is and does. She, her role and job is promoting the Three Lakes philanthropic venture to bring researchers, doctors, others into the world of pulmonary fibrosis. And what she has done in the last 6 months hasn't been done in the last 6 years that I'm aware of since my diagnosis. More has happened in the last 6 months about bringing together researchers, doctors, teams than I've seen in the last 6 years. And she has done that. Last night, I was fortunate to attend virtually an event in Boston where Elizabeth led an event for Three Lakes Partners Challenge, their $1 million challenge. And I was simply there as kind of a pulmonary fibrosis patient as a witness to what was happening. And it was an exciting event. I'm going to let her talk a little bit more about that. And he just recently built and finished, which I think I've mentioned to him a couple of times. I think it should be an architectural digest. It's beautiful. And then he's also a designer. He's also an artist and also does these crazy things like diving with sharks with no cages. So, but Noah brings with him just an incredible depth of knowledge on pulmonary wellness collectively. And today we're going to focus on one slice of that, which is fitness. But I hope we also have the opportunity to explore other things about lifestyle, including diet. So with that, Elizabeth, I'd like you to, if you would, just talk a little bit about Three Lakes Partners and what they're all about. And then we'll kind of get to Noah and we'll talk about fitness.
Yeah, I'm excited to talk to Noah, and I've heard so much about him, and I know that you have great respect for him and what he's done. You know, we've talked about Three Lakes before, so I don't want to belabor it too much, but Three Lakes is a venture philanthropy group dedicated to making progress in the fight against IPF. We're not judged on return. We're not judged on brand. We're judged on can we make a difference, and a significant difference for patients like you and all over the place. So the first thing that we did in April, we came out of the gate with a large $1 million IPF Catalyst Challenge. And we're going to give $1 million away to people who can create solutions that help improve patient and caregiver quality of life. We know this disease has many facets, from science to the quality of life issues. And we know right now patients like you and other patients that we've met around the country and around the world are battling these issues. And some of these can be solved with engineering-based solutions. So we put $1 million on the table. It's at challenge.ipfcatalyst.com is the website. And last night we had a live event in Boston, which I was grateful to be there, Bill, so much to the event via Skype. So that the people there and the entrepreneurs and innovators there could ask questions about what it's like to be a patient with the disease. So we held it at the Cambridge Innovation Center along with our partner Matter of Chicago, who helped arrange all of it for us. And really, it was an amazing event with about 40 people, but 40 really high quality people with great questions about the disease, great questions about the science, which I get a little over my skis on, but I do the best I can. But mostly just really people who are interested in making progress in this disease. We had bench researchers. We had people who ran advocacy groups. We had innovators and entrepreneurs trying to solve some of the oxygen issues that we face. So it was a great event. We're having another one in San Francisco on Friday night, Friday the 13th, around 5 o'clock at Galvanize, and it's at 44 Tahama Street, Galvanize is. And we'll have, cocktails and snacks, and we're inviting anybody in the San Francisco area to come and hear more about the challenge. We only have 14 more days for people to sign up for the Catalyst Challenge, so we're trying to get as many people as we can to sign up and get involved in this because we want to have high-quality submissions. I'll tell you that we've had 170 people sign up. We've had about 35 people start the application process. We hope we can get to 40 or 45. And from there, we'll pick 3 winners that will get $333,000 each. And the really all we're judging on is, will it really improve the patient's quality of life, and will it be a sustainable solution? So Again, your presence there last night was so amazing because I think people really got to understand what it was like to be a patient. Hearing it from me is one thing. Hearing it from you and the way you articulated it is a completely other thing that I think was really a benefit last night for everybody.
Well, thank you, Elizabeth. And no, what can I say to start this? Because you just cover all the facets of pulmonary wellness. You know, we've talked in the past several times, and I've been a guest on some of your wonderful webinars. I'm not sure the number now. They have to be into the double digits.
50
webinars you've done,
50.
and covers the whole facet. But can you talk? I guess from a 20,000-foot view, looking down to start our discussion. People that have pulmonary disease. In this case, we're talking primarily about pulmonary fibrosis. They face a unique set of problems, and they come in a lot of different stages and places because some patients are on oxygen and they're all but wheelchair bound and sometimes wheelchair bound as well. And the other end of the spectrum, you have patients that are sometimes newly diagnosed that are fully mobile. They exercise. When I was first diagnosed, I was still running 10Ks and doing swimming events. So you have that full spectrum. If you look at that patient mix and you look at pulmonary wellness and fitness, kind of talk a little bit about it from your standpoint of how it fits and how important it is or could be.
Okay. First of all, thank you for having me here. It's a pleasure, Bill. Anytime I can do something with you and Elizabeth, I appreciate the opportunity from Three Lakes Partner. The thing you just said basically. Can I talk about everything? And it's really appropriate. People don't realize how appropriate it is because when you are diagnosed with a disease, and it doesn't really matter if it's IPF or COPD or, severe arthritis or MS or no matter what it is, okay, lifestyle plays a tremendous role in all of it. And, a lot of times people think that there's going to be one silver bullet and that's going to end all the problems. But the problems and therefore the solutions are so interlaced that to talk about one without talking about all the others doesn't really make a whole lot of sense. And the same thing with living with this disease. It doesn't affect one thing. So in other words, the number one thing that we hear with IPF is shortness of breath and a chronic dry cough. Okay, so everyone can relate to that. And like you say, okay, well, I'm short of breath when I walk uphill, I'm short of breath when I walk up the stairs, and I'm short of breath when I run for the bus. So that's often how it starts for people. And one of the things, I'd say the main difference between IPF and COPD, and I'm not talking about the disease, pathology, but I'm talking about in the medical world experience with it, is that IPF is newer. It affects, not as many people, not as much in the mainstream. And so very often the diagnosis comes way after, we're down the line. Okay, when we've gotten way downstream and we're like, wait a second, how did we get here? First, maybe you were told it was asthma. Then maybe you were told it's COPD or emphysema. Then maybe you were told it was this or that. And, the thing about interstitial lung disease is that they're very complex. And it doesn't matter if it's IPF or any of the other ones. There's not a whole lot of people who are absolute experts in treating it. And so a general pulmonologist is not always going to be able to pick up IPF or any of the other interstitial lung diseases because they're complex and not everybody sees them all the time. That's a lot of talk. So I would say, to make a long story short, but I realize it's too late for that. So the things that I think are most important are we have to, number one, get educated. I think that people have to understand their disease, and I think they have to understand all of the manifestations of that disease, and they have to understand the potential things they can do to impact those manifestations, but also to see how they all affect each other. So what do I mean by that? So initially, people start to get short of breath at high levels of activity, and they will often attribute it to, well, I'm getting old, or I've put on some weight, or I've been less active, and then they start to avoid or eliminate or modify all of the activities that they do that cause them these symptoms. And as a result, all of the muscles that you use to do those activities all the systems, including the cardiovascular system, the pulmonary system, the endocrine system, the neurologic system, become less efficient, and then the whole body becomes less efficient, and you become short of breath at lower levels of activity. But as I say over and over again, breathing is a multifactorial process. It's not just a matter of lung function. Now, in IPF, there is absolutely a lung function issue, okay? People can't take a deep breath. And as things go on, they have to take more breaths in order to reach the same volume. So as an example, if the average person breathes 6 liters per minute, we'll say 6,000 milliliters. If normal respiratory rate is 12 to 20 breaths per minute. So let's do a little math. I'll do it for you, don't worry, but just think about the concept. So if you're breathing 500 milliliters of air per breath, okay, that means that you take 12 breaths per minute, or rather, if you're taking 12 breaths per minute, you're going to get 500 milliliters of air per breath, right? If you're breathing 40 breaths per minute, as many people with IPF do, particularly during activity, you're getting 150 milliliters of air per breath. Now, why is that so significant? We have our trachea, and our trachea is dead space, okay? It's anatomical dead space, meaning that we cannot get any air that's in the trachea into our lungs and therefore into our bloodstream. We're not moving oxygen into the bloodstream. So if you think about when you get very short of breath and you're going, the average person can take about as many milliliters of air in their trachea as pounds per body weight. So if you say a 150-pound person, and that's 150 milliliters of air in the trachea, and I told you if you're breathing 40 breaths per minute and you're only getting 150 milliliters of air per breath, then guess what? All that is going in and out of your trachea, and your oxygen diffusion and saturation is going down, down, down. That's one aspect of it. I'll shut up for a second so you can ask the next question, because I'll bring the other stuff back around in a few minutes, because, again, I'm going to kind of weave it in throughout the rest of this thing.
Well, based on that, on the patient, I have seen that desaturation over time. 6 years ago was swimming events, running, all that kind of stuff. Now, I still run, but I have an oxygen tank I cart around. I'm working on a solution to swim. It's difficult to do. So if I understand what you're saying, if I'm in better condition, do I get more? This question, do I get more oxygen in my lungs if I'm conditioned versus not being conditioned? If I exercise more, will I be more conditioned or less?
Absolutely. So that's a great question. And, that's really the key to the exercise, okay? There's a lot of misconceptions about exercise and respiratory disease. And the average world, in most of the world of pulmonary disease and pulmonary rehab and pulmonary physiology, people have this idea that you can't change lung function, and guess what? You can condition the skeletal muscles and make them more efficient. Now, this is what I mean when I talk about breathing being multifactorial. It's not just lung function. So how your body uses oxygen is based on 3 main things. It's based on a lot of things in general, but the 3 main things are how well your lungs move air in and out, how effective your heart is at pumping blood, and how efficient your muscles are at using oxygen, okay? All 3 get better with activity. All 3 get worse with inactivity. Now, again, over and over again, people will say to me, that's a bunch of, this guy is talking BS and you can't change lung function. I know you can change lung function. How do I know it? Because I've seen it happen over and over and over again. Now, that being said, in IPF in particular, lung function changes quickly at times, okay? So while you may not see an improvement in your lung function, although I have seen patients with IPF who have shown improvement in their lung function, we might be able to make it decline slower or hold it where it is at its best. But back to the idea of what lets your body use oxygen, if you have a car and the car has an old motor and the oil filter is filthy and you don't have the right amount of air in your tires, that car is going to get less miles per gallon. So miles per gallon is the best analogy, in my opinion, for how your body uses oxygen. So if you change the oil filter, well, then you're going to do a little better. If you put the right amount of air in the tires, you can do a little better. If you change your motor, you can do even better. If you do all 3, then that's even the best, and your car is going to become much more efficient. So again, it's not like you improve your heart, improve your lungs, improve your muscles, and they add, they multiply. So yes, and the beauty of that, it's kind of like paradoxical in the sense that the beauty of that is as your body gets better at using oxygen, you use oxygen more efficiently at all times. So in other words, you're going to be more efficient during exercise, you're going to be more efficient at rest, you're going to be more efficient at sleep.
Now,
yep.
If I can, I have
Sure.
a question, and then we have actually a question from one of the participants.
Sure.
The question I have is, and I heard this from the daughter of a patient, and she said, my dad won't exercise because he thinks it's counterintuitive, and you just kind of addressed that, which is he thinks that if he does that, then that could cause an exacerbation, which then causes him to go downhill quicker. And I've heard it from other people who said it was such a hard thing to get my wife to exercise, to get her to do anything because it's uncomfortable and it feels counterintuitive. What do you say to those patients? So that's my question. And then when you answer that, I'll ask the question from the participant.
I say this. I say if it were easy, everyone would be in shape. It's that simple. But for me, being in shape or not being in shape doesn't impact whether or not I can get to work or not. I could eat a burger and fries every night and then lie in bed watching Golden Girls, and still I'll probably be able to make it to work. When you have IPF, the stakes are much higher. And I would say this is your lifeline. I would say that the exercise and the nutrition and the management of your stress and anxiety are the crucial factors, as are the new medications for pulmonary fibrosis, as is prevention of infection. So if you say exercise is going to cause an exacerbation, then I would say you don't understand the physiology of exercise, and you don't understand what an exacerbation is. So when we talk about an exacerbation, we talk about, a worsening of symptoms. Sometimes it could be that you got sick, you got an infection, you got the flu, you got a common cold, okay? But the thing is that how would exercise cause that? It can't, okay? Not exercising can cause you to become weaker. They did a study at one time where they put a college football team in bed for 30 days and they lost 50% of their muscle strength. So I would say to somebody, listen, of course it's going to be hard, but certainly it's not going to be as hard as doing nothing, okay? IPF, I could describe it as the ocean. So you're swimming against the ocean's current. And IPF is bigger than you, it's stronger than you, it never gets tired. So if you do nothing, yes, you're definitely going to get worse. But it's like, and I hate to use this analogy because it's also misinformation and it's disrespectful to sharks. But it's like if you were to be shipwrecked and you're now standing on, you're hanging onto a piece of driftwood. And, I hate to say it because it's not true because I've been there and the sharks don't do anything to you. But it's like, are you going to sit there and wait and bake in the sun and wait to see what sea animal comes and takes a bite at you? Or are you going to swim? If it's me, I'm going to do everything I can. So what are the most important things? The most important things are the new medications, the anti-fibrotic proliferation medications that are out there, of course, but that is not going to make you better. Okay, that's the biggest misconception. Is people think, they're like, yeah, I started OPEV, I started, the other one, which I'm drawing a blank on right now. Estes, right. So I started OPEV or I started Estes, and I don't feel any better. Well, guess what? That's not what's going to make you feel better. It's not. So forget it. Okay? It might be what's going to, over the long term, make your disease go slower. But you know what's going to make you feel better? Getting up off your couch and moving, eating better. If you're overweight, then losing the weight. But that's a whole different thing with IPF, and I'll talk about that a little bit later. But managing your stress, right? Because it's a super stressful thing to not be able to breathe. So it's educating yourself. If you're eligible for the medications, yes, take control by exercising, but doing it right, under the right circumstances, eating well, managing your stress, preventing infection.
So we have a question from Michael M., who said, are there clinical trials around IPF? If so, are there the same problems in clinical trial enrollment as in other diseases? I know the answer to both of these, but I'm going to let you take that, Noah.
I'm going to say, I know there are clinical trials in IPF. I'm going to say, are there problems? I don't know because I'm not involved in any of them. I run a rehab center here in New York City. I run my Facebook group. I do my webinars. I'm not going to say I'm completely insulated, but I have a lot on my plate, and we're doing our own in-house stuff. So I will let you take it, Elizabeth.
Well, and Bill, I think you probably know this too. With every clinical trial, finding patients that fit the actual qualifications for those trials sometimes are difficult, depending on where they are, especially if they're in one geographical area and not others. So especially in a disease like this, which is considered a rare disease. So I think there are issues with trying to get people into clinical trials, just like there are with other type of rare diseases, because of the qualifications and the criteria that you need to be able to qualify for it. How long have you had the disease? Do you have any other comorbidities? Are there any other things that you need to look at? So with clinical trials, there's always that battle. But yes, there are clinical trials going on now. Matter of fact, I think there are more potential drugs in the pipeline, and we talked about it tonight, that has ever been for IPF. So I think, and I'm a little hesitant to say the number, but I think it's over 20 that are in different phases of trials. So you've got, phase 1, 2, those types of things. Bill, and maybe you can address that even more.
Well, I think the other thing is part of it. There is a number of different organizations that are addressing the clinical trials. One of them, my good friend Kamathi Stem has a company called Monarch Bionetworks, and she basically puts together groups before trials. In other words, she will enlist you and help you organize your data, your information, your records, and then when trials become available that fit your profile, she's there as kind of the buffer between the pharmaceutical company and the patients in bringing them together for trials. That's one incident. There's many others that are approaching the same business. So I think the trials are part of it. I think the number is greater than 20 worldwide. I think it's 20 in the U.S. But I know there's some really interesting things happening elsewhere as well. And Elizabeth, you're very involved in those things. I'm not sure if you want to talk about them or not, but they're really exciting things.
Yeah, I mean, I don't want to take up notes. I do want to talk about them at some point, and maybe we have a whole other webinar on the clinical trials that are out there and what we've seen. I will tell you that I have seen more passion around this disease, and I've been blown away from someone who's coming in from the outside to see the people who have researched this disease for years, unheralded, with not enough money to do it, and there's a lot of progress being made. And I know that's not fast enough for you, Bill, or for people who have it, but I promise you it's out there, and people are working really hard. Noah, I have one other question for you, and Bill can address this too. We talked about it last night. You talk about exercise being so important in lifestyle and getting out and keeping moving. Our friends at the Irish Lung Fibrosis Foundation created a program called 2,000 Steps, and it's an exercise program. Just take 2,000 steps a day. And they've paired up in peers, and we're talking about bringing that to life in a bigger way, and Bill knows about that around the world. But one of the things in the U.S. that's so frustrating is that the system is set up against these patients in a lot of ways. And in many places, and I don't want to say this is a blanket statement, but in many places, if you have IPF and you've been given an ICD-9 or 10 code for IPF, and for those who don't know, it's what happens when you go and you're going to get insurance and they code your disease, and your disease is IPF. In a lot of places, there's not a corresponding DME code or durable medical equipment code. So people who have IPF don't get the oxygen that they need for IPF. They get the oxygen they need for emphysema. And to your point earlier, at rest, an average emphysema patient needs 2 liters at rest, and an IPF average patient needs about 6. So they run out of oxygen before the month is over. And so what they do is they don't want to walk and they don't want to move because they're afraid to use their oxygen. This is a systemic problem, and it is crazy to me that we can't fix it. But I think that also is some of the fear that I've heard some of the patients say, well, I can't get out and walk because what if I run out of oxygen before the month's over? I can't get more. I mean, it's just unconscionable to me. Do you have any?
Well, yeah, it is. I mean, I didn't say before, just to clarify, I didn't say that a COPD patient requires 2 and an IPF requires 6.
I'm using that as an example.
Okay, so let's talk about this for a second. So there's a lot of stupid things that go on in the world. And it's kind of like Arsenio Hall would say, like things that make you go, There's multiple issues with what you're talking about. So let's just talk about the oxygen itself and the delivery of oxygen to patients with IPF, okay? I started treating patients with IPF in about 1995, okay? And yes, I was 3, but I was still treating IPF patients. So here's the thing. So this was under my mentor, Dr. Horacio Pineda, who is the director of the Cardiopulmonary Rehab Center at NYU Medical Center. And we would get a lot of referrals for patients with IPF, and they were often, and they still are often, rejected from rehab programs because their oxygen needs are too high or they're felt to be too sick, okay? So that's like saying, well, you know what? You're too poor to start a savings account, you know, or you don't make it doesn't make any sense, okay? So if you say, okay, you're too sick for rehab, that's like Alfred Hitchcock's movie Lifeboat, and we're basically saying, guess what? Go home and die, right? So my boss and I, my mentor, we started thinking about this, and we were like, this is crazy, because we'd have patients who come in and they're resting on oxygen at 90%. If they stand up to get up onto the treadmill, they go to 85%. And once the treadmill starts, they're in the 70s, which is terrifying, okay? Now, that's a problem, granted, okay? And so a lot of places are not equipped to handle this. A lot of pulmonary rehabs don't even monitor EKGs, which, you know, in my opinion, that's the way you push people to really monitor them closely. But the issue is, number one, an oxygen delivery issue. How do we get enough oxygen into you? So what my boss and I decided was, we were like, you know what, we don't want to keep turning these patients away. And if the idea is, okay, you're rejected because you're too sick, you're going to die anyway, we said, well, you know what, this actually gives us a little bit of leeway. Because if that's the thinking, then what do we have to lose by trying it, right? And that may sound sick, but think about it. Desperate times call for desperate measures. And so we started giving people as much oxygen as they need. And that means no cannula, okay? If you're using a cannula and you need, so first of all, let's talk about how much, let me frame it in terms of how much oxygen do you need. There's no answer for that, right? So if somebody says, oh, an IPF patient should exercise on 6 liters per minute of oxygen by a cannula, then you know they don't know what they're talking about, because it's sliding scale, right? That's how everything in your life has to be treated with IPF. And in the same way that a scuba diver has to use a depth gauge to know how deep they are, because you can't tell if you're 100 feet or 200 feet, and just like a pilot has to use an altimeter to know their altitude, an IPF patient has to use a pulse oximeter, because once you cross over that line of shortness of breath, you don't know if you're 92 or 88 or 85 or, 65 or 25, right? So I always say to people, rely on your instrument. That's going to be your guide. So it means if you're getting 6 liters per minute, because that's what your doctor ordered, which most doctors, let me tell you, most people don't get a prescription for 6 liters per minute. Most people get a prescription for 2 liters at rest and 4 liters with exercise, and you check your saturation, you're 80%. Guess what? That oxygen is almost useless for you. And you know what? It's a valid thought to say, yeah, I shouldn't be out walking at 80%, even though I'm on oxygen, because the fact of the matter is there's a lot of adaptations that occur when that happens. So there's cardiovascular implications. You're increasing your risk of coronary ischemia, meaning that the heart muscle is not getting enough blood. You're increasing your risk of arrhythmia. You're increasing your risk of pulmonary hypertension over the short term and the long term, meaning while you're doing the exercise, and also over time chronically, okay? So you're right. That is a daunting task for people, okay? So what can they do? First of all, the simplest thing you could do, and one of the greatest frustrations, is we have these portable oxygen concentrators, right? And trust me, people are getting rich as hell selling portable oxygen concentrators, right? The people selling them. And some of the people buying them are getting poor as hell, because they're saying, you know what, I only have $4,000 in the bank, but I'm going to use this $3,000 because I think this oxygen concentrator is going to be the difference between me not being able to live my life and me being able to live my life. And the problem with that is that, again, unless you are keeping yourself in the 90s, then sometimes even the charge and the problem and the effort you make to carry that around, it's like, what are you doing it for? You still have a hole in your boat. You're still sinking, right? So that's where pulmonary rehab is so crucial, because with my patients, okay, and this is what we started doing in 95, was we said, you know what, we're going to use our instrument. If we have to give this patient 100% O2, meaning that we're giving them 15 liters through non-rebreather mask, that's what we're going to do. And Bill, back to your point before, what we started seeing was now these patients that used to rest at 90 are now resting at 93 to 95 on the same oxygen level, right? And these patients that are exercising and going to, 85 when they're standing up are now at 90, and now they're exercising. So we will give them as much oxygen as they need, and we have some people who we have to blow 25 liters per minute on a mask through them. But that helps the body get better. So what I would say to people who can't do it, I'd say you have to do it. If it means that you turn your oxygen up, okay, and use a mask, because using a mask immediately is going to increase the concentration significantly, okay, and that's not going to work with the pulse ox, with the pulse. You have to do continuous, but you will often get better saturations using a lower liter flow that's continuous than using a higher number that's pulsed. And, the thing that people misunderstand is they think that these portable concentrators, they think that those numbers are liters per minute, and they're not. They're factory settings. So even if you have one and people think, well, mine goes to 5, that's not 5 liters per minute. That's a setting of 5. So it's, in a way, a false gauge. You know what I mean? So I say to people, turn it up as much as you need to remain saturated at 90%. And if you cannot remain saturated at 90% on that highest level of your machine, then by all means you have to decrease the activity for now and do more of it.
Bill, can you talk about what you talked about last night? Because I think this is really important. And part of the IPF Catalyst Challenge, not to get back to that, is we believe there are engineering-based solutions that can help fix some of these problems with these oxygen concentrators. And no, I couldn't agree with you more. It is a commoditized product. They're unbelievably expensive. They're ugly. They're not portable. They're not. It's crazy that this market is one of these markets that's never been touched. And Bill's heard me say this before. I want Dyson involved, right? Dyson took a vacuum cleaner that was a vacuum cleaner and made it into something spectacular. There's got to be a better way with oxygen.
I want Apple.
Apple. I mean, it's unconscionable.
Apple can do anything.
It's unconscionable that I can start my car from my phone, but I have to get up and walk to the other room to turn up my oxygen. That's insane. But
right.
Bill, talk about, you addressed this last night, and it was so meaningful, I think, because people really understood it, about your daughter's leg. And the fact that you couldn't fly and why you couldn't fly. Because I think, to Noah's point, this really does kind of make this issue forefront, which is one of the things we're hoping to solve with the challenge. And then I want to come back and ask Noah a question about exercise and the transplantation as well. So go ahead, Bill.
My story, I think, is echoed by a lot of patients, many of them, many that I know. My daughter's getting married in Breckenridge, Colorado. Well, that's a wonderful thing, but it's also a wedding happening at 9,500 feet. And at 9,500 feet, even the average person has a little problem breathing. For me, I'm only on oxygen when I exercise. I typically run about 6 liters, and I'm on liquid oxygen, which means I get a continuous flow. So I had to go from Dallas to Colorado, and I called my airlines to get a flight, and they said, sure. I said, I'm on oxygen. I have to be on oxygen when I fly because the pressurized cabin is about 7,000 to 8,000 feet. They said, oh, what kind of oxygen are you on? I said, well, I'm on liquid oxygen. We can't use that. I said, well, if I buy a concentrator, a portable concentrator, can I use that? They said, sure, but you have to have 3 times the number of hours of batteries on your concentrator. So I had to get 9 hours of battery to fly up. I had to buy a unit. All said and done, it's about $5,000–6,000. So Patty and I ended up driving up. We drove up, and I didn't need oxygen until I got through the Eisenhower Tunnel. It's about 7,000 feet, give or take. And the whole time I was there for 3 days, I was on oxygen 24/7. And typically running about 4 to 6 liters based on like you taught me. I was looking at that pulse ox and watching it closely. And so I don't think I'm that unusual for patients. Many patients end up being housebound. They literally can't get out because the oxygen companies, an interesting number to me was in the Dallas-Fort Worth Metroplex, there's about 1,600 patients, give or take. According to UT Southwestern, when I was given a prescription for oxygen, there was 4 people on liquid oxygen. There's now 5. I'm one of the 5. I had to make 27 phone calls to every oxygen supplier in our area to finally find one that would kind of say, oh, okay, let's get liquid oxygen. However, this is interesting, I got the liquid oxygen device, the tank, But then another company gives me the liquid oxygen, and they had to give me a floor unit because they charge the insurance companies, Medicare, for that. Because that's how they make their money.
Right.
And they take those tanks, which are cash cows, and if you use a tank today and someone else will use it tomorrow and the next week, every time they're being used, it goes ka-ching. It's a cash cow. It just keeps on circulating. So this whole oxygen thing, it's incredibly frustrating. You have people using oxygen that don't understand what they need, nor should they have to, being prescribed oxygen by people who don't have a clue, doctors and nurses, about what is there or the options, under a company that's making a profit who wants to do the most for the least to make the most money, under guidelines and rules by the federal government, by Medicare, and by insurance companies, and is the most chaotic soup of misinformation and ignorance I've ever personally been exposed to.
So, to your point, you say that you're not unlike the average IPF patient. I would say that you're very unlike the average patient. I've always called you an outlier, but you're an outlier on the high end, meaning that most people are not as fit as you. Most people don't have the exercise background as you. So based on everything you just said, it's that much worse for them, okay? But part of the problem also is you're right. People don't get an opportunity. Like I have a patient now with IPF. She's on a transplant list. She's trying to get an oxygen concentrator, but they won't let her try the different concentrators. So you might get patients lined up with a concentrator that is not adequate for them. And then if they want to make a switch, they get charged hundreds of dollars, right? So that's crazy. So what we're trying to do right now is we're trying to have as many different types of concentrators here in the center so that we can say, is this really adequate for you to help the patient, make the right choice? And even though that seems like an expensive prospect, it winds up being so much cheaper because people I have to comment because here you are, a center in New York who's enlightened. How many centers across the United States do you think do that? My guess is one. I don't think any. Yeah.
Why not? Why don't they do that? Why don't they have access to those things so they can show patients or test patients or have something in a region where people can test the oxygen? That's crazy.
Listen, if there were enough people, there aren't even enough centers for rehab. Okay, in New York City, one just closed down because rehab got almost a 50% cut in reimbursement. Right. So one of the biggest programs that's been here for 20 years just closed down. I think that it's all a money game. But like another frustration is like Medicare will pay to rent a unit, right? So by the time they're done renting that unit, they've wound up paying 5, 6, 7, 8 times the cost of the unit to begin with. So I agree, it should be everywhere. And what we're trying to do is we're trying to make ourselves a sort of a testing ground for New York City where you could come in and we have all the units, because why get something that's not going to work? It's like getting, it's like having a computer that doesn't do what you need it to. You need Microsoft Word. It doesn't have Word.
Yeah. It's interesting that you bring this up because, we've been traveling around the world, and I will say that as frustrating as it is for what Medicare will cover on pulmonary rehab, I mean, to me, that's insanity. I mean, if anything needs to be covered with this disease, that's it.
Yeah.
Because it is the thing that's going to help
I agree.
manage the disease. But when we were in London and we were in the UK, there's virtually no pulmonary rehab.
Oh, for
None.
sure.
And those patients can't even get on the drugs until their forced vital capacity number is under 70.
Right.
By that point, I'm
Yeah.
not sure how much effectiveness those drugs will have. We have a question from Rick. He's asking what is the safe saturation level for an IPF patient during exercise? Is there such a thing, or is it because of the heterogeneity of the disease?
No, there is a thing. What I will do is I want my patients to be 93% plus. Now, a lot of people are hearing that and saying, wait a second, I would never be at 93, I'd never be able to exercise. You can't say what is safe, what's not safe, because with IPF, you don't have a choice. You're going to be saturated, okay? Now, that being said, somebody with IPF who's at 80% is different than, let's say, if you or I were to all of a sudden be at 80%, okay? We are not used to that. And Bill, back to your point about driving to Colorado, that's actually a better way of doing it. Okay, so if any of you have ever had, because what that does is by driving as opposed to sort of just flying, you acclimate. So in other words, for those of you that are aquarium fish keepers, you know that when your fish come, you spend several hours putting a little of the water from your tank into the water from the bag and so on and so forth. It helps the fish acclimate. Same thing with breathing and going to altitude. Now, here's the thing about oxygen saturation. I would say that I want my patients above 90% minimum. And the reason why 90% is such a crucial number, people don't understand this either, is there's something called the oxygen hemoglobin dissociation curve. Don't worry about that. It's super physiologic, and you don't have to know that. All you have to know is that it's not a linear curve, meaning that it doesn't go straight up the line. How your body uses oxygen is not linear, and it means that every percentage point is not equal. So the way the curve is from 100 to 90, it's pretty flat, okay? And then at 90%, there's a big dip because it's an S-shaped curve. So what that means is, like they say, that first step is a doozy. So between 90 and 100, your body is actually, there's less difference between 90 and 100 than 90 and 88 because of the nature of that S-shaped curve. And it has to do with partial pressures of oxygen in your blood. So I would say, what's the safe number? I want you above 90. Now, if you can't stay above 90, you still have to do something, okay? And we know that there's a major issue with maintaining saturation when you have IPF. So I would say this. I would say you have two choices. You can either oxygenate and, in order to meet the demand, or you can lower the intensity. Okay, now a lot of programs I've seen and I've been to, they will lower the patient's exercise intensity to maintain their oxygen saturation. And when I ask them why they're doing that, they say, well, this is how much oxygen they use in the street. No, that doesn't make any sense, right? Because our goal in rehab and our goal in exercise is to give you the maximum workout possible by hook or by crook. And that means if I have to give you 25 liters of oxygen on a mat, now, your body doesn't know you're getting the oxygen. Your body only knows that you're doing the workout, and it's going to make adaptations based on that. And so while I realize that the average person cannot get that much oxygen in the home setting, you can in rehab. And what I try to teach rehab professionals over and over again is give them as much oxygen as they need and then push them. Yes, they will get short of breath. Yes, your patient will look uncomfortable because they're going to be uncomfortable. Yes, they're going to sometimes be bluish in tint, okay? That's the nature of the disease, but that's what we have to do to get the ball rolling. So I would say take as much oxygen as you need. If you're using a home concentrator and it takes turning it all the way up, so be it. But again, paradoxically, over the course of time, our goal is that your body get better at using oxygen.
How do you get people who have maybe newly diagnosed patients and their caregivers who might be watching this, how do you get them to start? I mentioned this earlier. I heard from a husband of a patient who said, I can't get her to do it. I just can't get her to do it. And I think it feels so daunting. How do you get people to take that first proverbial step, as it were?
So everybody who comes to me by physician referral, okay? And what I say to doctors, because you're right, I don't get the resistance as much as the physician gets the resistance, because by the time somebody's in my office, they've taken the first step. And it's like once you're in that car wash, once you pull up and you're on the track, the car wash takes the rest of it, okay? And that's kind of how it is here. And I say to people, when doctors call me and say, I have a patient, they really don't want to do it, I say, get them to come here once, okay? And when they come here and they see a place that's blue and purple and gold and has art everywhere and great music and fish and a dog and the staff even knows what they're doing, they come back. And, it's a little different for me working here on 38th Street than it is in a hospital, because in a hospital, it's a very tightly monitored situation, okay? And ours is very tightly monitored, but a lot of people think like, wait a second, what am I doing here? And the patient is a consumer. I'm a private practitioner, so a patient has an option of going someplace else. Of course, my goal is to gain that patient's confidence, to give them what they can do, and to then improve upon that, okay? I had a dentist when I was a kid, and he used to give every patient sunglasses and a mirror, and he'd say, if you raise up that mirror, that stops my machine, okay? So it gives the patient a feeling that, you know what, when this is getting too much for me, I'm going to raise this up and this drill is going to stop and I'll get a little break. Same type of thing here. Everything is done to the patient's tolerance. We're monitoring them at every step of the way. So all our patients exercise while on an EKG. So I'm looking at your heart rate and rhythm the whole time. I'm checking your blood pressure every 5 minutes. I'm checking your oxygen saturation continuously. Okay? So the idea is that I can say to somebody, I know this is going to be terrible for you. Okay? It's going to feel terrible. It's like, you know, when you're in turbulence, right? In the back, we're like, oh my God, what's going on here? We hope the pilot's not in the front saying, oh my God, what's going on here, right? But the pilot's looking at their instruments and they're saying, you know what? It feels bad to you, but I promise you, you're okay. Like, I just wish a pilot would come on during that and say, you know what? I know this feels rough, but trust me, this is nothing for us, okay? That's what we do. We say, you know what? I know you feel short of breath, but look, your heart rate is fine. Your rhythm is fine. Your blood pressure is fine. Your oxygen is fine. You're safe. You know what I mean? And we keep them safe. And because of this, you get to see things ahead of time. You know, we don't like surprises. So we'll do it to your tolerance. And I say to my patients all the time, you have ultimate veto power. So if you say stop, we stop. That's it.
No, I guess I have two questions because I know the answers, but I'd like you to express them.
Sure.
You're a fan of treadmills.
Yes.
And secondly, you have a unique patient using a treadmill.
100.
I believe 102.
100. I've had 102 before, but my current patient is 100. Yeah.
All right. Now, talk about treadmills and why you are such a fan, and how patients. I have a treadmill at home, as an example. Everyone, unfortunately, doesn't have that luxury.
Right.
If I don't have a treadmill at home, and treadmills are that important, much more important, I think, than walking around the block. How should they approach fitness? How should they approach your theories of revitalizing their lives and their lungs and their breathing?
All right. So when we talk about me being a fan of treadmill, I'm not like a gushing fan of the treadmill. I'm a scientist of the treadmill. Okay. So the treadmill is the best exercise for you. And you know, for the people that say, I don't care. Listen, people, when it comes to exercise, everybody has an opinion. Okay? You could go to New York Sports Club and say, what's the best exercise? And you get all these guys that are going to say, women, guys. Everyone's got their own opinion. I happen to have an opinion on it. Why is my opinion my opinion? Because I've been doing this for 25 years, a quarter of a century. Okay, I've seen thousands and thousands of patients. I've done tens of thousands, if not probably hundreds of thousands of visits. I see it over and over again, and I know what works best, and I know what doesn't work best. Your body is sport specific, and by that I mean activity specific, right? So nobody gets around town new stepping, right? Let's see. Everybody loves the new step. No, I haven't seen anyone new stepping around town yet. I see everybody walking around town, right? So here's some of the differences. The treadmill, number one. First of all, walking is our main mode of locomotion, right? Nobody takes the UBE around town. Although some people do. I do see some people exercising using like a recumbent bicycle. But here's the thing. If you need to walk, you have to walk. If you need to walk upstairs, the way you get good at walking upstairs is walking upstairs. If you need to climb a mountain, the way you get good at climbing a mountain is climbing a mountain, okay? It involves a lot of systems. Okay, it involves a lot of systems. And in order to walk, we need to be, first of all, we have to think about the metabolic load, right? So the metabolic load of walking is big. The metabolic load of walking upstairs is big. We have to lift our bodies up, move them, carry them essentially up a flight of stairs. So in order to do that, and this is what I try to get people to understand, both patients and professionals, is this. If your life requires this, I could exercise you here till the cows come home. And you're still not going to get any better at this, okay? Same thing with lung function. If your lungs only go to here with the exercise, but they have the capacity to do this, okay, but you only do this because you're not working out vigorously enough, you cannot improve lung function. So if your exercise doesn't challenge you enough, it's not going to be good enough. Again, bicycle. You can bike till the cows come home. But the recumbent bike, here I am. I'm leaning back. My trunk is supported, right? So here's the difference between recumbent bike and upright bike. Here, I could just lean back. It's like a chaise lounge. Even when I'm sitting up, I have to balance my front muscles, my anterior muscles of my body, which is the front, with my posterior muscles of the body, which is the back. I have to balance myself side to side. and there's metabolic activity going on just to stand still, but you're only moving your legs. Now, same thing with walking. Now, why is a treadmill such a great activity? The treadmill simulates walking, okay? But the treadmill does some really good things for you, okay? First of all, by holding on, and this is what people don't understand. This is a great piece of information that so few people understand. When you move your arms like this in space, this is what we call open chain activity. And when I use my chest muscles, when I'm doing an open chain activity, my chest muscles do things like this. My shoulder muscles do things like this. My back muscles do things like this, right? When you hold on, when you fix your extremities, either by holding on to the treadmill or by leaning forward on your leg or leaning on a table, you are now doing what I call a closed chain activity. And I say I call it. I didn't invent the word. I'm not gonna take a page from government, but I don't think I invented the word closed chain activity. But I've never heard anyone talk about it in the context of respiratory disease before. But when you fix the upper extremities by holding on, all the muscles I just talked about, the muscles of your chest, the muscles of your back, the muscles of your thorax, all work in reverse. And instead of doing these things, these are fixed, right? So then my thorax opens and closes, and it elevates my rib cage, so it helps you breathe, okay? That's one thing. The treadmill also helps you move your legs back a little bit, so you're able to do things on the treadmill that you can't do outside, but it makes you better at doing the things outside because you're using the exact muscles and systems that you need to walk outside. Now, a lot of times people say, I can't walk a block outside, and then I give them one of those 3-wheel rolling walkers, and I say, let's go for a walk, and we walk around the whole block, like 4 blocks, right? And again, a big part of that is because you're fixing the upper extremities. I think the treadmill has no equal when it comes to rehabbing patients with respiratory disease and cardiovascular disease. And if I only had a treadmill, I could still get the same results that I get now. Now, if you don't have a treadmill, what could you do? Anything is better than nothing. So like Martin Luther King once said, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. Any way you do it, and I'm not paraphrasing, but you have to keep moving. So Nike says just do it. I say just do something because you have to do something every day. So if you don't have access to pulmonary rehab and you don't have access to a vigorous treadmill workout, you can certainly get the workout in other ways, but then you have to do it more often. So it's like you don't get the $100 bill, right? So instead you make your money $5 at a time. So you have to make more of it. You have to have more transactions. So go ahead.
Really, one of the things about this that's interesting too that I've learned over the last year, and again, I am by no means an expert in this. I've just talked to a lot of patients and a lot of clinicians. Is the solitary nature of this disease, and the solitary nature, especially when you don't want to leave the house or you don't feel like you can leave the house, whether it's the cold that's affecting you, or you're worried about an infection, or you're worried about running out of oxygen. And we've often said that exercise could be more of a peer-to-peer, and we've seen apps that are coming out, and we've seen other things. How important is that for some of these patients to have a buddy? And you'll laugh, Noah, but I'm a Peloton freak. So I have a bike.
Peloton's great, yeah.
I have a bike that's connected to other people biking at the same time, and there is something about being able to
100%.
have people motivate you or compete with you that drives you a little bit, or say, hey, you did better today than you did yesterday. And these principles kind of adult learning and gamification where people who come to pulmonary rehab, is it important that they look and see what they did last time or what they did this time? And is it important that they have a buddy? And then we have a question from the audience once you answer.
Sure.
And
I agree with you 100%. I'll tell you, this is kind of interesting, but I believe I have had a greater impact on respiratory disease in the world through my Facebook group than I have in 25 years of practice. And that may sound crazy, but I've always been frustrated. Like, people ask me all the time, will I open a center with them? And I don't want to worry what's going on the next block, let alone, while people are exercising. But through my Facebook group, I have been able to teach people these principles that they can then take to their rehab center or employ in their homes and share with others, to the point where now my 10,000 person group I rarely have to speak because everybody else knows this stuff and they're teaching each other. So I think peer-to-peer is crucial. I agree there are apps that are going to make this, possible, even more possible. And, I'm working on one myself that, is going to do just that, because you're right. It is often solitary, but I'd say that, the digital, social media has allowed me to reach so many people in so many countries that I never would have been able to meet.
No, can you give it a plug for people who don't know what it is? What's your Facebook group's name?
It's Ultimate Pulmonary Wellness.
Ultimate
Pulmonary Wellness. Or if you friend me, I will add you to the group. But,
that site is linked right off of the PF Warrior page on Facebook or the PF Warrior site. We link directly to it and encourage all of our PF Warriors to buy your book or use your book. I know you're giving it away in this session. And Pep, I want to talk about that a little bit because the Pulmonary Wellness book you've created, it is the definitive guide to living with pulmonary disease, bar none. It addresses diet, issues, philosophy, all of it. What is the URL for that, Noah?
It's pulmonarywellnessbook.com.
Easy. Pulmonarywellnessbook.com.
Yeah.
And they go in and read it and download it and use it and have access to it.
Yeah, you can read it for free. Again, it wasn't something that I started as a moneymaker because you know what? If somebody doesn't have $5 or $20 to buy the books, I'm not going to deprive them of that care. So it's free if you want. If you want the hard copy, they're available too. But anyone who has a computer can read it absolutely free.
Let me throw the question here that we have. It's a little bit not related to pulmonary rehab, and I'm not sure that we're going to feel comfortable answering it. I think maybe. But Sylvia asks, hi, I have PF autoimmune, and my doctors won't let me try the new meds for IPF because my disease is inflammatory. I'm on prednisone, Celsep combo. I don't understand the difference from a treatment perspective. Why can't the new meds be used for both IPF and PF? I have a high-level answer, but Noah, do you want to take that?
I think it's beyond the scope of my knowledge, and I mean, the one thing I would say is that, when you have an autoimmune disease or when inflammation is such a huge part of your disease, you have to be careful in anything that's going to lower immunity even further because you're prone to absolutely everything. So it sounds like you're being treated with, steroids and, Celsep, which, I'm going to stop jabbering because I think it's beyond the scope of what
I think that's
a question for your doctor.
Yeah, I think that's probably the right answer, and I also think there's different mechanisms of action with disease, IPF versus an autoimmune disease, and so the drugs that are out there also from an off-label perspective. But I think it's probably a broader, and I would ask the doctor to explain it thoroughly why you can't be, but they're not going to put you on something that A is not going to work or B could harm you in another way as well.
You know what I would say also is that, to me, the person who I say I learned the most about PF from is Dr. Robert Kainer at Cornell and also Dr. Maria Padilla at Mount Sinai. And the thing I would say, I want to ask Dr. Kainer about this, and he was explaining in our webinar, and Bill, you could put that link up to the webinar, and that's the one with you and I and Dr. Kainer. But again, as I was talking about before, interstitial lung diseases are so complex. They're not straightforward. Not that COPD is straightforward, but there's certainly a well-traveled road of COPD. And there's not as much in the interstitial lung diseases. And the thing is that the medications that help some of them can actually be harmful to others.
So, no, Bill, I'm going to throw it back to you because we need to wrap it up. We've got about a minute left, so I want you to be able to say goodbye. But, Noah, it was amazing to be with you. Thank you.
Bill, you told me we had 4 hours to this.
Yeah, sure. Like you can afford that time, right?
But you know what? Bill, please just also link the talk from Dallas because that one is about 3 hours. And then that one, I feel like I kind of left it all on the field and said everything I want to say about IPF.
What I liked about the meeting in Dallas as much as anything, the content was wonderful, was the fact that you, at the end of an hour, you said, okay, I'm done. If you want to stick around, I'm glad to answer. People stuck around for another 2 hours with you, Noah.
It was great. I loved it. That was my...
Well, I have to say thank you. Thank you for doing this. And thank you for supporting all of us every day and all the things, the many things you do. greatly appreciated. And Elizabeth,
Thank you.
I'm so glad you were here, and I'm so glad you had the chance to meet Noah. He's one of my
Absolutely.
favorite.
Thank you.
Thanks.
Thank you.
We'll do another one soon. No, take
Have
care.
a great day, everybody. Bye-bye.
Bye, Bill.
Bye-bye.
See you soon.
Bye.